moving on to the next topic in this session, which is the topic of this session is role of interventional pulmonology in daily clinical practice. As in the last lecture, Swapnil has opened the gate for the interventional pulmonology. Now we will have this wonderful presentation from Dr. Prashant N Chhajed sir, who needs no introduction. He is the one of the pioneer in a field of interventional pulmonology, and he is doing lots of interventional procedure. And sir is
25 minutes time notice, please.
now I am handing. Okay. And now I hand over the mic to the sir for his presentation.
So, thank you very much, Dr. Pathak Saab, for this very kind invitation. And I think the the foundation for this lecture has already been very well set by our earlier speaker. And so what it's made my talk easier. What I am going to do in the next 25-30 minutes is just give you a practical overview of interventions in daily practice. You know, this is the word, daily clinical practice. You must have seen many things such as navigation systems, there are volume reduction systems, thermoplasty. Yes, they are done in select centers, but the point is in daily practice, you know, what all can be done and what is very important, and the numbers are quite high. The spectrum has already been discussed by the earlier speaker. So let me start with the case presentation. I'll run through this very fast. 54-year-old female. She presents with breathlessness. Saturation is 91% on room air. X-ray shows bilateral reticulonodular opacities. PFT shows severe restriction, and there is a significant desaturation on the 6-minute walk test. If you see the HRCT chest, it says, ill-defined reticulonodular opacities in both lung fields showing a centrilobular distribution. Fine reticular densities are also present. Now there is an interstitial lung disease pattern, and she's a very young lady. We need a very precise diagnosis for this particular patient. Okay, so it is a ILD under investigation, and we do the regular workup. Connective tissue disease markers are normal. IG was normal. IG specific for pigeons dropping is normal, and therefore at that time, this was done many years ago. The discussion was, should we do a VATS? So VATS was in fashion. That is video assisted thoracoscopic surgery, open biopsy. They were in fashion. Or the other option was a transbronchial biopsy. VATS came into fashion because you could get, or became important in practice because you could get bigger tissue and you could make a better diagnosis. But and she was an ophthalmologist wife, so she said, okay, we first like to do we want to take the chance of doing a transbronchial lung biopsy. Even if the tissue is small, they wanted to take a chance and see if it is not diagnostic, then we would move to a VATS surgery. So this is how a transbronchial biopsy is done. The forceps is passed through the bronchoscope. You just saw that. Okay, this is a very important procedure, can be done at almost all institutions which have bronchoscopy, therefore can be done in a routine practice. And this on the C-arm, you can really see how the forceps opens and a biopsy is taken in this particular case. Okay, and this is the histopathology report. Okay, the histopathology says interstitial pneumonitis with the possibility of parasitic etiology suggested, because they were also cross-section showed calcified parasitic larvae. What is the point? I'm not trying to show you a rare case. I'm trying to show you that transbronchial lung biopsy is a tool which can be used in regular practice, and whenever it is appropriate, we should optimally utilize these tools to obtain biopsies. And this is what the histopath was seen in this particular patient. So we could get a diagnosis, and then we went ahead, we found out that she has a history of trekking in the Himalayas, so that's a big different story. And then, she had craniocephalous granulomas also in the muscles, so that's a different story. But the point is that in this particular case, transbronchial lung biopsy was very helpful. Now, this is another case, okay? 58-year-old male, a young individual who has got cough, has got breathlessness, brother has died of interstitial lung disease, spirometry is normal, diffusion is impaired, okay? And he is now diagnosed to have a interstitial lung disease. So in interstitial lung disease, there are some diagnoses which you can make using a CT scan, and for some cases, you need to do a biopsy. transbronchial lung biopsy in that earlier case, because she had reticular nodular opacities, it gave a better chance of a diagnosis. But now transbronchial lung biopsy, as was shown by the previous speaker, is now replaced by a cryo lung biopsy. You don't need to do surgery, but through the bronchoscope you can do cryo lung biopsy and you can make a diagnosis. For this particular patient, this was the differential diagnosis, and we had needed why do we need a precise diagnosis? We discussed this earlier also. No more empiric therapy. As far as possible, we must get as precise diagnosis as possible, and whenever it is feasible, we need a histopathology diagnosis. And again, transbronchial cryobiopsy. These are the details. I'm not going to go into the details because they were already described earlier, but I want to show you a video about how a transbronchial cryobiopsy is done. This is how it is done. You need a balloon, you need a cryoprobe, and then this can be done in the bronchoscopy room, in the endoscopy room. It has to be well equipped. I have an anesthesia, I've got a boils, we can intubate the patient, we can do a rigid bronchoscopy in these patients, and we can also do C-arm. So basically it's not a regular bronchoscopy room, it has to be a well-equipped bronchoscopy room where you can give general anesthesia also. And then in this particular case, we could make a diagnosis of hypersensitivity pneumonitis. So again, I've shown you transbronchial lung biopsy, and now it has matured to a cryo lung biopsy, and that has allowed us to reduce the VATS biopsies because there's more morbidity, more cost involved with VATS biopsies. We move gears now. 58, again, a 58-year-old gentleman came to us. I mean, this is almost 15 years ago. We did this case, and this patient, clearly you see here, there's a left lower lobe patch there on the X-ray, left lower zone. And then for this particular case, as was shown earlier, CT guided biopsy was described. So we did a CT guided biopsy, and in the CT guided biopsy, it is necrotic tissue, no granulomas. Basically, it is a non-diagnostic. It's typically very surprising, but if you have a proximal obstruction, then the distal lung biopsy may be non-conclusive. In those days, PET scan was available. We had this is a high-profile patient. We were able to do a PET scan for this patient. So the PET scan now clearly you see here. You can see here there is the PET uptake is there in these areas here, and these are the mediastinal lymph nodes which are present. Now, how do you biopsy a mediastinal lymph node? Something is called a bronchoscopic needle aspiration. Bronchoscopic needle aspiration is done very simply. You use a simple flexible bronchoscope, the regular bronchoscope which you can get at the, even in the third tier cities, easily available. You take a needle, you pass the needle through and through the airway here. Where is this gone? Yeah, cursor. And then you aspirate. If you have a neck lymph node, you do a fine needle aspiration. Similarly, you can do a needle aspiration of the mediastinal lymph node, and you can make a diagnosis. And this is how a bronchoscopic needle aspiration is done. Okay. Now again, I've shown you this. In this particular case, yes, we could make a diagnosis. Now again, things have matured. You were shown about EBUS. When the needle was put in the earlier case, you could not see where the needle was going. Now we do CT guided procedures, we do ultrasound guided procedures. So this is a bronchoscopic ultrasound guided procedure. And in this particular case, what do you see here? You can see the needle going here. Look at the second image here. You can see the needle going into the lymph node here. There's a pulsating blood vessel here. And under image guidance, you can be sure where you have gone in, where you have taken the, and from where the biopsy is taken. So this is the research we did. Now, we are celebrating 20 years of EBUS since we published the first paper. And very good to see that the first paper which we published is now standard of care. Yeah. So this is how EBUS is done. And that now we come back to the case which I showed you. That individual in whom the CT guided biopsy was not conclusive. And then if you see here, if it is showing here, this is a sub-centimeter lymph node. The lymph node is 8 millimeters. And in 8 millimeter lymph node also you can put in a needle and you can get a biopsy. And clearly this patient had adenocarcinoma of lung. And the important thing here is what? We could do immunohistochemistry. Even you can do molecular studies using EBUS samples. So these are the papers. I'm not going to go into the details. The message from these papers is that you can make a diagnosis of lymph nodes, you can do immunohistochemistry, and you can collect enough material also for biomarkers, because nowadays in lung cancer, it is not only chemotherapy which is given intravenously. About 35 to 40% of patients with lung cancer, if you do these biomarker tests, now will qualify for oral treatment, tablets or capsules treatment, and you can achieve that with this particular test. So these are the different ALK fusion, you can do ALK, EGFR, other biomarkers can be tested. You can do a 12 gene panel in the same EBUS sample and get a more precise diagnosis for targeted therapy. This is the paper which we've published using a 21 gauge needle. These are the good biopsies which you can get with EBUS TBNA, and that gives you enough material. And all these procedures are done in the endoscopy suite. Patients go back home. From entry to exit is 6 hours. Okay, so they are gone as a daycare procedure. This is a paper which we published, and we showed here that we've actually not shown here, we've reviewed that this is a very good modality for diagnosis and staging of lung cancer. Lung cancer, the therapies have evolved a lot in the last 10 years, and the survivors have also improved. Let's shift gears to something more simpler. We see TB. Somebody asked the question in the press conference about simple TB, complicated TB, and Dr. Nangia described about drug-resistant TB, also described about normal TB. And again, you don't want to do empiric treatment, you want precise treatment. So if you have somebody who's got these big lymph nodes here, depending on which geography you are, it could be a sensitive TB or a resistant. This is a patient who's got 45-year-old male, fever, cough, weight loss, received multiple antibiotics, no benefit, and we did EBUS for this patient, and we aspirated blood, pus, sorry. And it was TB gene X positive, and there is no rifampicin resistant. Culture shows pan-sensitive, patient responds very well. What's the big deal? Next case, 40-year-old female, diabetic, hypothyroid, multiple course of antibiotics. We do a EBUS for this particular patient, and it eventually turns out to be on culture, grows to be MDR TB. So on the X-ray, you cannot say whether this is a sensitive TB or a multi-drug resistance, and that's where this technology comes to use, where you can make a more precise diagnosis in terms of TB. This is the first paper which was published, shows we published this from India 2019, and which the world first paper shows the utility of EBUS TBNA technique in the diagnosis of drug-resistant tuberculosis. So this is the value of this technique, and we know that TB is one of the most common infections in our country and can be utilized well. Again, moving gears, you were shown rigid bronchoscopy, foreign body aspiration is good. I just want to show you that using rigid bronchoscopy, sharp foreign bodies can be safely removed using rigid bronchoscopy. This is, root canal is happening almost, I think all of us will, like we get a cataract surgery, we might get a root canal surgery, so common. But that root canal screw can be aspirated, it can go into the lung, and this can be removed. It's a sharp thing, and rigid bronchoscopy is a tool which can be used to remove foreign bodies. Now this is the airway. Airway showing that there is a big obstruction there. Now you want to remove this obstruction. Patients are difficult in breathing. There is stridor. Okay, 23-year-old female, she's got weight loss, difficulty in breathing, hemoptysis, she's got wheezing as well. Now, this I showed you is being done using an endotracheal tube. So if you do not have in that situation a rigid bronchoscope, and if you are trained well, you could also do this through an endotracheal tube. And look at this, this entire growth could be removed within 20 minutes using bronchoscopy. This turned out to be tuberculosis. Now, a lot of patients undergo ventilation, you do endotracheal intubations, you can get airway stenosis. Now, this is a patient, look at that small, this is the airway, okay, and this is our main airway, which is 14 to 16 to 18 millimeters in diameter, and this was hardly 2 or 3 millimeters. We can do balloon dilatation, and with balloon dilatation, we can open the airway. This is called as a balloon tracheoplasty. Again, this procedure can be done approximately 20 minutes, can be done in the endoscopy room, and we do this routinely. Look at this, that's a small stenosis, and you see this post-balloon tracheoplasty. We can use now, suppose, I showed you a TB obstruction, I showed you a foreign body removal, I showed you a narrowing, I showed you a removal of a mass which eventually turned out to be TB. Look at this. You can use lasers also. Does this work? Yes, it works. So lasers can be used to debulk. There are different types of lasers available depending on the institution. You can use laser, electrocautery, or you can use also a diode laser. And look at this, you can actually remove the tumor. This allows the individual to breathe well, okay, and gives a lot of symptomatic relief. stent insertion was shown. If the airway is narrowed, okay, it's compressed from all sides. We know that stent insertion, we think about coronary stent insertions. Airway stent insertion is also useful and possible in select patients here. What you see here is one of the first stents we did using the UltraFlex stent in 2001. And you know, I'd like to show this video. Look at this. And the UltraFlex stent continues to be one of the better stents, metal stents in selected patients with lung cancer. And you see how the airway completely opens up. This is the paper which is published in Chest. We showed that if you use lasers, if you use stent placements, these individuals can have a good survival and they can also qualify for good chemotherapy. In our setting, you can use a combination of electrosurgery and laser. This patient was offered actually a pneumonectomy. They were referred to us for removal of this the lesion, turned out to be a carcinoid. And look at this, I'm now using electrosurgery. I'm not using laser. Electrosurgery is available in all hospitals. Okay, all hospitals, all OTs available. It's a question about using the available equipment well. And here you can see here, this was removed. I moved this forward in the interest of time. Oops, doesn't work. It doesn't like that I move it. Never mind. So let's see. In interest of time, can I move this? It doesn't work. Anyway, so you can use electrosurgery in interest of time. I'll go ahead. You can use cryotherapy also to remove these tumors. Cryotherapy, I showed you cryolung biopsy. Same technique can be used to remove tumors. Same technique can be used to remove foreign bodies also. Quickly, a few more, a couple of slides more. Now, this is a case of CA, advanced CA esophagus. This patient has got an esophageal stenting done. Mind you, esophagus is present behind the airway. If the esophageal tumor expands, if you put in a stent, it can compress the airway, okay? And now after the esophageal stent and the esophageal tumor is expanding, patient comes with difficulty in breathing and comes with stridor. Look at this. I mean, there is a, I'm not sure if this projects here, but if you see here, this is the esophageal stent, and look at this airway. This airway should be big. This is completely narrowed here. And for this particular patient, we went ahead and we did what is called as a metallic stent here. A Y stent was put in here. This, I showed this paper. This is not my paper, but a paper published from India, which describes this technique good and this experience in a good way. So a Y stent can be put in, and you can almost create a new artificial airway. Let me show you a better illustration. 65-year-old male, small cell carcinoma, not responding to chemotherapy. You want to give radiation. This is the trick here. He cannot lie down. How he just cannot lie down to get radiation therapy. So what we did for this patient is, this is how you create an artificial airway almost. Okay, we put in a Y stent, open up the airway. The patient can lie down now, and now this patient qualifies. One is his breathlessness becomes less, and he qualifies for radiation. The point is, all these techniques are available, and we can use this appropriately in selected patients. Tracheoesophageal fistulas are very common. Okay, so tracheal fistulas, you can put in a stent. I'll not go into details. You know, people can look up this paper. It's one of the largest series published using stents for airway fistulas. We published this some years ago now, and it shows that in fistulas you can use metal stents, sometime in the airway alone or in combination with the esophageal stent to get a good relief for these patients. Pleuroscopy is a very important procedure. Is done for diagnosis of either a pleural effusion or it is done for treatment of a pneumothorax. Okay, so quickly I just want to take you through this. A 56-year-old female, she has adenocystic carcinoma of maxillary bone 4 years ago. Now she has cough, breathlessness and effusion. 4 times tapping is done. She started on anti-TB treatment empirically. She is not responding. Okay, when there is a history of cancer, I think one should not start anti-TB treatment. Then she comes to us. Look at this, at 4 o'clock. I got a time here in the evening. Again, a repeat pleural effusions after 4 tappings. We put in an intercostal drainage tube, relieve her breathlessness, and now we want a diagnosis for this patient here. So look at this. This is a pleuroscopy which is being done. You see the intercostal drainage tube here. Multiple tappings lead to a lot of adhesion, so some adhegiolysis has to be done. You have to break the adhesions, and after breaking the adhesions, we find that yes, there is a tumor there. We take the biopsies there, send it for testing, and because after we are able to remove all the adhesions, the lung is expanding. Because the lung is expanding, we can also do what is called as a pleurodesis for this patient here. Look at this. This is the, remove all the adhesions. Biopsy is being done here. So we could find these nodules, discuss with the family that yes, this seems to be malignant, and we can save an extra procedure at a later date. And I'll show you after this. I'm sorry I can't forward this in interest of time, but now after this is followed by talc pleurodesis. So what we do is you spray talc over the lung and allow the lung to expand, and there's a pleurodesis which happens, and after the pleurodesis happens, it prevents the recurrent effusion. That's what's the role of pleurodesis. And look at these x-rays that follow up also. She got a lot of relief from the pleural effusion. Last case and last 2 slides. Pneumothorax, middle-aged gentleman, non-smoker, 4 episodes of pneumothorax in 2 years. Every time ICD is inserted, and for 1 week, he's admitted for 1 week, lung expands and goes back, comes back after 6 months. This time he comes to us with the ICD. Okay? And what we did for this patient is, this is a pleuroscopy we did for this particular patient here. And if you see here, after pleuroscopy, we did a talc pleurodesis for this patient. And there were small blebs here. Those blebs were less than 1 centimeter. And if you have blebs less than 2 centimeters, you don't need to do anything. You can just go ahead and do a pleurodesis. If it's bigger, then you call the surgeon friends, and you may want to do some surgical procedure. What I show you here is if you can remove that timer, it shows we published the long-term outcome of the talc pleurodesis in spontaneous pneumothorax. It's a safe thing. There are many concerns which people have, and I just showed you, this is where I worked, and I mean, this shows 1974. I could find the report in my previous institution. The first talc pleurodesis using thoracoscopy, this is the report, was done in 1974. It has stood the test of time over 50 years, and it is a safe procedure in selected patients. And this is that detailed the detailed paper which you can look up. This has already been discussed. Tunnel pleural catheters can be used for a trapped lung, malignant pleural effusions, recurrent pleural effusions. They've got a good role, and I think I will not go into the details of this. There are other techniques like navigation bronchoscopy, bronchial thermoplasty. I've got those slides here, but I think that's not daily clinical practice. Today's topic was daily clinical practice. I've shown you cases of daily clinical practice, and I hope this helps you in your practice and for the young students in their exams. Thank you very much.
Non-academic question.
Yes, sir.
Being a medical superintendent of Sasandala Hospital, CBUS का जो cost of taking this CBUS in our facility we don't have. Can you suggest me how much the cost is going to?
So now, this cost, I think, if you allow me to say this, is a perspective. It depends with what perspective we look at it, because, it's giving a diagnosis. I think as pulmonologists, somehow we have been limited, I say we, including me, have been limited in the vision and limited by the costs, etc. I'm not saying costs are not important, sir. Okay, costs are important, but then we have to look how much benefit a particular modality is giving to that particular individual, and for the individual, that's the world. If you give a precise diagnosis to the individual, I mean, it's his life for him. Okay, so I think that's one perspective. I will come to your perspective also about the finance. So I think we have to always remember a diagnosis. I think in medicine per se, I think diagnosis is the most important thing. I think the specialist, I think our job to make a diagnosis, treatment, ek baar diagnosis de diya, you go home, and somebody else can also treat. That's not the point. Now, coming into a medical college, etc., the cost of EBUS. So I think, sir, it's not so expensive. You can say that, 30,000, 50,000 expensive, but then you can also say it is not expensive. You have a one-time cost of the equipment, and I think the public institutions have got CT scans, they've got MRIs. You can justify that. You can justify a cath lab. You can justify robots. Why you can't justify an EBUS? 50 lakhs, 60 lakhs. I hope I made my point, sir.
Thank you so much.
In your institution,
Sorry, sir?
in your institution, this procedure,
Yeah.
how much patient has to pay?
So I do this in a corporate setup, and the cost of the procedure in my setup, I think if you do on a daycare basis, is the procedure cost is about 38 to 40,000.
That's quite okay.
Yes, yes. Of course, there are
Quite
additional
affordable.
charges. There'll be anesthesia charges. There'll be lab charges. If the patient stays back, there are different charges. But I'm talking the cost of the procedure.
डॉक्टर
सर ये कॉस्ट है ना सर, ये इंस्टीट्यूशन पे डिपेंड करता है सर. अभी अगर आई विल टेल यू माय यू नो इन द मेडिकल कॉलेजेस they get the thing, then उनको needle cost आता है. You have to see what is the recurrent cost of the thing. So I think the cost, I just say, I think it is inappropriate to discuss the cost. I think what we need to do in academic meetings, I'm sorry to be more provocative and so strong, we need to discuss the benefit to the patient. I think that should be the focus, and I think we need to work out how we are going to, yes, some cost is there, how we'll work out and bring the benefit to the patient, I think. So I think it's a mental block. I've had it, and I think Vivek will also agree with it. Prabhu Desai is there. Where is sir? He's there. Prabhu Desai, you will also agree. I think the diagnosis is where, he's a man of tremendous clinical experience, and he will also agree. I think the focus is diagnosis, sir. Cost is a mental block. I'm not trying to be arrogant. I'm just using this platform to convey a very important thing which I learned over 20 years. Yes, sir.
Yeah, I enjoyed your talk, Dr. Prashant. I have few questions where we get involved as a surgeon in making a diagnosis, like staging for lymph node staging for lung cancer. So the question is, if you have the facility of PET scanning, surgical mediastinoscopy, and this
Yeah.
TBNA,
Yeah,
which one
I see.
you think
Yes,
is
yes.
the best?
So the question is, if in a lung cancer staging, you have PET scan, you have mediastinoscopy, and you have EBUS available. One must understand that PET scan will only show you hot areas. PET scan will show you which are PET positive areas. If PET scan in a patient with lung cancer, if a PET positive lymph node or a PET negative lymph node, say if a PET positive lymph node was always cancer, and if a PET negative lymph node was always not cancer, then we would not need mediastinoscopy. A PET CT would replace tissue diagnosis, but that's not what happens. Whenever a PET CT is positive in a lung cancer patient, it can be reactive lymph nodes. We've seen granulomatous response to malignancy, that can be PET positive, and we see that it's not uncommon. Often we get anthracotic lymph nodes which are not PET, which are PET positive but do not harbor malignant cells. So I think, and we get tuberculosis. So I think a PET positive lymph node should not be taken as malignancy positive, and I think we need to chase a PET positive lymph node. If it's a PET negative lymph node, we know in adenocarcinoma, you can get a false negative. If the lymph node is 1 centimeter or less, the PET is not so sensitive. In adenocarcinoma, it may be infiltrated, but it can still be PET negative. So again, you need to sample the lymph node also. So I think the jury is clear. If it is a PET positive or PET negative, you need to sample. Now the question is, will you use mediastinoscopy or will you use EBUS now? Now, EBUS is something which I said is done on an outpatient basis or a daycare basis. I will not get into the cost because I think cost is a very sensitive thing. But we know that this mediastinoscopy, we know people who do it on a daycare basis, on a single day admission basis, but mediastinoscopy has certain limitations. One is the expertise available. You mentioned that if both are available, okay? Mediastinoscopy cannot, you can't sample the entire mediastinum as far as the staging is concerned, because with mediastinoscopy, only enlarged lymph nodes can be sampled. You're the best judge in that. You need modified mediastinoscopies to sample certain lymph nodes, and the hilar lymph nodes are out of question. So if you have hilar adenopathy, you will need some other technique. And the advantage of the EBUS is, in staging, we have to do systematic evaluation. You have to start, we don't just target lymph nodes based on what is seen on the CT scan or the PET CT. You have to go and start systematically. Hilar lymph nodes are seen, subcarinal are seen, paratracheal are seen, aorta pulmonary are seen, precarinal. So I think EBUS allows you to sample all the lymph nodes systematically, and I think that's the advantage of EBUS. So to answer your question, if EBUS is available and mediastinoscopy is available, EBUS is the first choice, and that's what Tata Hospital has also done. Tata Hospital has excellent thoracic surgeons, as you're aware. They can do mediastinoscopy, in the back of the hands, but they also use EBUS TBNA because it offers a more extensive and more precise staging opportunity.
So, if I make a statement that surgical mediastinoscopy, it can be done as a day care procedure, so there is not much of difference hospital stay-wise. It is a gold standard for making a definite diagnosis. It is most sensitive, most specific compared to TBNA. And also, majority of the stages, I understand about the hilar area, you may not be able to reach, but 2, 4, 7, all these stations, you'll be able to, sample. That's not difficult.
Yeah. So in our paper, which we published with Yasufuku, and I think we discussed about the utility of EBUS in staging. I think there are plenty of trials. The initial trials were done as a non-inferiority. So they considered mediastinoscopy as the gold standard, and then you did EBUS to show that it is non-inferior to mediastinoscopy. So the first trial showed that EBUS is non-inferior. And there are subsequent trials now which have clearly shown that EBUS is superior in systematic sampling of lymph nodes, because there are some lymph nodes which may not be seen on imaging. There may be a gap between the imaging and when you do the procedure. So I think therefore I think almost mediastinoscopy is now being replaced by EBUS TBNA in, I think.
And another, because very commonly we come in our surgical practice referred by the chest physicians, the patients, they have the sort of loculated effusion or even empyema, and they are not, means they attempted, they could not get the pus out, or they put the chest tube, there is nothing coming out, those kind of thing, and when they get a CT scan or ultrasound, they find that there are loculated pocket of pus or collections. So in those cases, because if it comes to me, the first thing which I do normally, because I usually put that chest tube, and once we are sure that it's in place, then we attempt that intrapleural fibrinolysis. So what do you think is the role of intrapleural fibrinolysis?
So I think the question is about using fibrinolysis in empyemas and their loculated effusion. Yes, intrapleural fibrinolysis does have a role, but I think the role is a selected role. I think, it depends at what stage if the patient has come in early, I think at that point, if you put in a tube and if it's not too organized, I think there is a role for intrapleural fibrinolysis. Typically, unfortunately, what happens in our practice is, we are not the first point of contact. Typically we would have patients seen by the at level 1, level 2, and the complicated cases land up with us. So what is my approach when a patient comes to me? I think if there is a empyema, there is a loculated effusion, there is multiplicated effusion, is a thickening of the pleura, I think it straight goes to the surgeon. I think the role of pleuroscopy in the endoscopy suite is mainly diagnostic. If you have a little bit of effusions, you can, a little bit of septae, you can do the adhesiolysis. But I think the endoscopic, the pleuroscopy we do in the endoscopy room does not replace the VATS which you do, where you can do a more systematic decortication, you can do a more systematic, I think that helps more. So I think I'm very clear on this. As far as yeah.
Thank you very much, sir. So to present Memento and Angavastram to Dr. Prashant, sir, I would request Dr. K.K. Gupta, sir. Please, sir.